Hello, everyone, and a big thank you for you being here today. Would like to extend a warm welcome to you all for this webinar on fibroids from Scientific Sangam Series, organized by ISOPARB Prayagraj in association with Allahabad Obs Gyn Societies and academic partner NAARI Division of Jagsonpal Pharma Ltd. For medical management of uterine fibroids, Jagsonpal presents to you Yuliprist 5 milligram tablet and fibristone 25 milligram of mifepristone. Jackson Paul would like to thank the experts and participants for joining us today. We welcome the organizing chairperson, Dr. Ranjana Khanna, madam, founder president, ISOPARB Prayagraj. She is also the ICOG governing council member, vice president, FOGSI 2017. The organizing secretary for this webinar today is Dr. Chitra Pandey, ma'am. She is Vice President ISOPARB Prayagraj, past President of Allahabad Obs Gyn Society. Welcome to you all. We begin the session with a prayer and hand over to Dr. Ranjana Khanna, ma'am. Thank you.
Very good evening, friends. At the outset, I welcome all of you to this webinar, which is the 30th in the series of Scientific Sangam. It is being organized by ISOPARB Prayagraj, and it is in association with our Allahabad Obs Gyn Society. A very, very warm welcome to our chief guest, Dr. Sunita Tandulwadkar, and our guest of honor, Dr. Sheela Mane. Dr. Sunita, I think everyone is very well aware, is the president-elect of FOGSI. 2025, she'll take over as President FOGSI in the beautiful and glamorous Geo Convention Center in Mumbai. She is the head of the department, OBGYN, and Chief IVF and Endoscopy Center, Ruby Hall Clinic, Pune, and advisor and consultant, Dr. D.Y. Patil, IVF and Endoscopy Center, Pune. She is a very dashing personality. We have seen the amount of hard work she has put in, and her extraordinary achievement is that India's first stem cell baby and world's first at the age of 45, 16th April 2018. And both of us were co-VPs together in 2017 when Rishma was the president of FOGSI, and we had a wonderful time together. I would request Dr. Sunita Tandulwadkar to please say something about the topic and bless our webinar. And bless me in particular, since I am going to stand for President FOGSI and Dr. Preeti Kumar for Vice President FOGSI.
Thank you. Thank you so much, Ranjana, for having me. Believe me, pleasure is completely mine. It's so lovely to see senior people like Abhilasha Chaturvedi madam, Manju Varma madam, Uma Jaiswal, and my lovely darling Preeti Kumar. I have a special love and affection for both of you. You all know Parul. Thank you so much. And I see Sheela. Sheela, hi, thank you. Sheela is one of the dynamic, but I'm surprised to see Sheela is not in a PPH webinar, but in a fibroid, showing her mastery in all the subjects. Ranjana, I wish you definitely a very, 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 warm voting, roll of voting from all across the country. You are always smiling. I still remember I used to ask you, how can you think about going for a presidency? And you taught me, अरे उसमें कुछ नहीं है, वो chair पे बैठा तो सब आ जाता है. I can't forget that word. And I told you 7 years ago, I think, no, Ranjana, I don't think I am ready for a president post yet. If you remember our conversation, and we had a lovely time during our vice presidency, we became a thicker friends.
Yes.
We used to have a gala time together. Preeti, I observed you very closely during your 3 years Safe Motherhood Committee. For me, you are the winner for last 2 decades. forget only for your ear. Let me tell you, I am always honest. I'm honest. Even I have not done the work what you have done during your, see, we all have done. It's not that we have not done, but the creativity, the strength, the massiveness, reaching up to the paramedical staff, where when it is PPH or when it is a motherhood, you have not given importance to only obstetricians and the residents. You involved all the staff who are equally important. So many times before you reach, the sister is the one who is taking care of the patient. So Preeti, I really admire. Second thing I admire with you is your leadership. I know your 40 committee members. I know many of them personally. And the way they got involved into, see, you know what? As a committee chairperson to do the job, because you are getting a name, fame, everything is different. And for Preeti, for her committee to work is a different ballgame altogether. So Preeti, I know you will be probably the VP and the president. I always tell president of FOGSI, if anyone from UP, apart from Ranjana, if I think over, is always a Preeti Kumar. And you will definitely, because organization also need the leaders who can take the organization to the level. And I see that, and you will be working in my ear, irrespective. If you win the election, you will not say me, oh, mujhe next year kaam karna hai. First perform in 2025, then 2026. And Chitra, thank you so much for your so many phone calls. Thank you, darling. You are amazingly good. Today, you are going to talk about the fibroids. When you are talking about the medical aspect of the fibroid, infertility aspect, or the fibroids at cesarean with Shobha and Niharika, I think Ranjana, yourself with the best of the chairperson you have chosen, I'm very sure this is fibroid is my topic of the heart. And I do have the patients coming from all over the globe, but the fibroid management from wherever that, it doesn't matter the racial, genetic, geographical, religion, the differences, but the treatment depends upon their size, number, location, and what patient wants altogether. And I'm sure this topic will attract a lot of crowd and they will be enriched. Whatever the seminars are happening, I think this may be 1,000 times the fibroid has spoken in last 5 years, but every webinar has a different angle, has a different ball game. Yuliprist always say sometimes it works, sometimes we feel the FDA has not approved, sometimes we are scared. How much we should be scared? I think today after your talk, people will learn about it. So thank you for giving me an opportunity, and welcome to AMOGS, welcome to Pune. And in August, we are having a very big conference, second weekend of August, 8, 9, 10. That is Aspire coming in Pune along with ISAR. And I invite you all, block those dates, those who love infertility and those who want to be an infertility expert, please join us. Thank you so much. And please book your Geo AICOG 2025 right now. You will see, I know the hotels and all. Please book it immediately. Go on booking.com and book it. I don't know.
We can't obviously afford to miss seeing you becoming the president.
You know what? It will be the history. 2026, I'm taking ISAR presidency in same Geo.
I know that. I was there in Bhubaneswar also.
We will create the history both consecutive year.
Yeah.
But we created the history. The only who will be, I'm today in 2024, FOGSI president-elect and ISAR president-elect. Thanks to each and every one of you. I mean it from bottom of my heart. I'm so thankful to every one of you for giving me this opportunity to serve beautiful to organization. Thank you so much.
Thank you so much, Sunita. Your words have boosted our morale. I'm sure. And now I would like to invite and welcome Dr. Sheela Mane. Everyone knows her in FOGSI as the PPH lady, but she is much, much, much beyond that. And currently, she is DNB faculty at KCG Hospital, Bengaluru. And in fact, she is also going to be the ICOG chairperson, I think in 2026, na, Dr. Sheela?
Yes, Dr. Ranjana.
Yeah, she has worked and worked and worked for FOGSI. And of course, very rightfully,
Thank you.
and especially when you demonstrate those sutures, I've seen you do it, and you do it so methodically and so well that you almost feel that, yes, this is the uterus and these are the sutures being put. So, welcome, Dr. Sheela, and I would love you to bless the webinar.
I would like to congratulate the Allahabad ISOPARB Society for bringing out such an excellent academic program throughout. I would like to congratulate Dr. Manju Varma, currently as the president, and the secretary Chitra Pandey, as well as Uma and Parul for having this scientific session, and none other than Dr. Sunita, who is the expert in this, But now I must say that fibroid is really becoming very important topic, because we have seen the increase in the incidence. We are seeing the girls coming at a younger age, and we know that there is a lifestyle changes, marriages, and having very few children. So we are seeing more and more cases of fibroid diagnosed, and we have to really look. So the way you people have framed your scientific program, where it also includes the medical management, and I think which is really very important, as well as the infertility, the surgical part, that is myomectomy. And I would like to give my best wishes to all the speakers as well, that is yourself, Dr. Ranjana, Dr. Shobha Gudi, and Dr. Niharika. And best of luck to you as well as Dr. Preeti. We know all of you have worked very hard and in UP, and continue to do our work. So all of us are karma yogis, we keep on working, we don't look at the fruits what we are getting, but our only thing is that we just work, and we have seen that. And I would like to wish best of luck to you as well as Dr. Preeti.
And now I would request Dr. Chitra to take over the program.
Good evening, everyone, and a very warm welcome to all the dignitaries, all the faculty members, and all the delegates on board. We are going to start this very, very important webinar, Scientific Sangam, a landmark webinar. This is number 30, and it includes ISOPARB as well as all the members of Allahabad Obs Gyn Society. Now, I would like to invite a chairperson, Dr. Neeru Sahu. Dr. Neeru is very active member of Allahabad Obs Gyn Society and ISOPARB Prayagraj. And she is director and consultant obs and gynecologist at Usha Hospital. And she is also ex-treasurer of Allahabad Obs Gyn Society. And our expert for this session is none other than Professor Preeti Kumar. Ma'am is chairperson of Maternal and Perinatal Committee, SAFOG. She is chairperson of Safe Motherhood Committee, FOGSI, 2020 to 2023. She is also committee member of MFM Committee, EOFOG, Joint Secretary of India Gestosis Chapter. We have already seen her organizational skill, and she has been organizing secretary of so many prestigious conferences, including AICOG 2020 Lucknow, IH 2018, and many more. She has been vice president of Lucknow Obs Gyn Society 2020 to 2022. She is core member of many committees, and she is recipient of many, many prestigious awards, including Appreciation Award by Health Minister for ensuring safe motherhood in UP, year 2020, and recipient of Women Achiever Award by Lucknow Obs Gyn Society. So we welcome you, Preeti Di, and our heartiest best wishes are with you. We are sure to see you as Vice President FOGSI in coming years. And now I request Dr. Neeru Sahu to introduce our next speaker, our very own Ranjana Khanna ma'am.
I think Chitra, just I'll take just few minutes because I know Dr. Sunita and Dr. Sheela Mane will leave. Maybe she are busy. Both of them are busy.
Okay,
I
sure,
just
sure.
want to extend heartfelt gratitude, Dr. Sunita. I know you personally, but because I've seen you, a very emotional person, a very spiritual person, I must say, and excellent leadership quality. That is why she's leading so many organizations. So she had been president of IG. She will be taking over as president of FOGSI. And also, and the next thing what I have observed is she's very true to her words. Whatever she says, she does it. So that's a beautiful beauty of Dr. Sunita Tandulwadkar. So thank you so much for being here, and thank you for all your kind words which you have extended for Ranjana ji and for myself. And of course, I'm also thankful to Dr. Sheela Mane ji. And I wish you all the good luck, Dr. Sunita, for your presidentship. And we will definitely be with you for whatever.
You all,
Yeah,
Manju
yeah,
ji, Chitra, you cannot be behind it.
yeah.
Apart from
Everybody,
Ranjana and Preeti.
yeah, everybody will be with you. So all the best wishes for you. And thank
Thank
you, Dr. Sheela ji, for all your kind words and your support, which is always extended for the UP Society and all the members from UP. Thank you so much. Thank you for being here. Now, Renu,
गुड इवनिंग
Chitra,
एवरीवन
yeah, please.
एंड डॉक्टर नीरू साहू और ये मेरा बहुत बड़ा सौभाग्य है कि आप इतने सारे अच्छे और इतने प्रोमिनेंट पर्सनालिटी के आगे मैं कुछ भी नहीं हूँ और मैं जिस पर्सनालिटी को इंट्रोड्यूस करने जा रही हूँ वो भी किसी परिचय की मोहताज नहीं है। हमारी अपनी रंजना मैम जो ICOG गवर्निंग सोसाइटी की मेंबर है 2021 से 25 तक, और उनके क्राउन में इतने सारे सितारे हैं कि मुझे उनमें एक एक करके बताना बहुत मुश्किल काम है। और मैं हमारी प्रेसिडेंट रह चुकी 2017 से, और मैं उनके लिए ज्यादा शब्द न कहते हुए मैं कहना चाहूंगी कि वो अपना टॉक स्टार्ट करें, मेडिकल मैनेजमेंट ऑफ द फाइब्रॉइड।
I think Neeru, just
वेलकम
few words.
रंजना मैम।
Few words more about Ranjana ji. Ranjana ji is very kind-hearted, very warm person. She has already served this organization as vice president of FOGSI, and she deserves to be there as president of FOGSI. We will all support her as far as possible. We have seen her leadership quality. I've never seen any time she's stressed out. I have attended several conferences what she has organized. Amazing person, full of love. So all the best wishes, Ranjana ji. It's very important to say that you are contesting and we have to support you for, at every step.
Thank you so much, Preeti. Thank you so much.
हम भी सभी चाहते हैं कि आप प्रेसिडेंटशिप में पहुंच जाएं। ये हम सबकी हार्दिक इच्छा है और हम सबकी अभिलाषा है कि आप प्रेसिडेंट में हमारे सीट पे पहुंचे। हम सब गॉड से प्रे कर रहे हैं कि आप वहां तक जरूर विराजमान हो।
Yes. So
Thank
now
you so
I
much.
request Ranjana ji to talk on medical management of fibroid. She will be talking on this topic.
A very good evening, friends. I'll be speaking on a very, very important topic, and that is medical management of uterine fibroids and update. Uterine fibroids are benign tumors of muscular and fibrous tissues, typically developing in the wall of the uterus, and up to 40% of women over the age of 40 have uterine fibroids. The Ministry of Health and Family Welfare, GOI, say that nearly 20 to 30% of Indian women in the reproductive age group have fibroid uterus. And at any given time, nearly 15 to 25 million Indian women have fibroid. The types, I think all of us are very familiar. Submucosal if it is inside the cavity, intramural if it is in the wall, subserosal if it is outside on the peritoneal cavity, and cervical, of course, if it is in the cervix. But now what is important is the FIGO classification system, which has brought everything out so clearly. And when the staging is done on ultrasound, we can have a mental picture of the exact location of the fibroid. So we start from stage 0, which is pedunculated intracavitary, and reach to stage 7, that is subserosal pedunculated. And in between, we have these various, I think all of us are very well aware of the classification. So what is the etiology of uterine fibroids? Because we have to know the etiology to treat the condition. Estrogen, it was always known as an estrogenic condition until the role of progesterone also came into the picture. So estrogen has been implicated in the growth of myomas, and studies show that myomas contain estrogen receptor in higher concentration than the surrounding myometrium. Myomas may increase in size with estrogen therapy and in pregnancy. They are therefore not detectable before puberty, and after menopause they tend to regress. Progesterone increases mitotic activity and reduces apoptosis. Genetic predisposition has also been seen. Pathophysiology of fibroids includes the action of growth factors, genetic mutations, changing dynamics of cellular processes, forces from the surrounding extracellular matrix. We won't go into the details of all this. Risk factors: early onset menarche, late reproductive years, obesity, family history, and race. Blacks are more affected than whites. Symptoms: we all are very familiar with menorrhagia, pelvic pain, dysmenorrhea, anemia, infertility, bladder and bowel pressure. So how do we diagnose? History taking is always very important. And then physical examination, when we are doing a routine PV examination, if we find that the uterus is irregular outline, then we would like that the patient goes in for an ultrasound, and the best would be a transvaginal scanning of the ultrasound, because that would tell us whether there is any fibroid in the submucous area, intramural, or subperitoneal. So TVS is of utmost importance. Then we have the saline infusion sonography and hysteroscopy. That is a very important tool we have in our hands nowadays. And additional imaging, if you are suspecting malignancy, say in a postmenopausal female, if the fibroid size suddenly starts growing, then we can suspect malignancy, and in that case, MRI has to be resorted to. So how do we manage? It could be conservative, it could be surgical. Conservative, if there are no symptoms, observation only, just wait and watch. Or it could be medical. Then there could be minimally invasive procedure like magnetic resonance guided focused ultrasound, minimally invasive UAE, that is very popular nowadays in the States, in the Western countries, and invasive thermal ablation is also coming up, and surgical we will not go into. Now, coming to the medical management, what are the indications? In which conditions will you do the medical management? Number one is a symptomatic patient. We will not unnecessarily tamper with a patient who is asymptomatic. Perimenopausal female, because we have the feeling that if we are giving medical treatment and there's a period of amenorrhea and the patient slips into menopause, then the fibroids will automatically regress. So she'll be saved an unnecessary hysterectomy. Women desiring children and retaining uterus, for correction of anemia before surgery, to decrease the size and vascularity of tumors, and those patients who are unfit for surgery. Now, how do we treat? First is we have to treat the anemia. Patients are normally anemic because of bleeding, so hematinics are a must. Then antifibrinolytic drugs. Now, we'll step into the details. So antifibrinolytic drugs, tranexamic acid, the dose is 1 to 4 grams per day, and the advantage is that it reduces the blood loss and corrects the anemia. Disadvantage is that the size remains the same. GnRH agonists, they downregulate the HPO axis and inhibit the ovarian function. Leuprolide 3.75 milligrams every month, 3 to 6 months intramuscularly or subcutaneously. What are the advantages? It reduces the size of the fibroid by 30% and the size of the uterine volume by 35% within 6 months. But what is the disadvantage? There is an initial flare, hypoestrogenic effect is there, so loss of trabecular bone, and once you stop the treatment, again there is an increase in the size back to normal. Loss of plane is there, so sometimes surgeons find it very difficult to operate if GnRH agonists have been given prior to the surgery. Another disadvantage is that seedling fibroids are missed, and it is pretty expensive. But what is the current status of therapy? What is the expert opinion say? They say that GnRH analogs can be used prior to hysteroscopic myomectomy and hysterectomy to reduce the uterine volume and the vascularity. but they are not used routinely. GnRH agonist is not recommended before conventional and laparoscopic myomectomy due to possible loss of planes. So because of their side effect profile with climacteric symptom and loss of bone marrow density, so they cannot be used for more than 3 to 6 months. Coming to GnRH antagonists, they compete with endogenous GnRH for the pituitary binding sites, and there is no flare-up initial as seen as in agonists, and they rapidly suppress the gonadotropin release within 4 to 8 hours, while the agonists take 2 to 3 weeks for treatment. Activity is dose-dependent. Side effects include flushes and headache. And after therapy, however, agonist and antagonist, in both cases, the fibroids will go back to the original size. Elagolix and relugolix are the only GnRH antagonists approved by US FDA to treat AUB associated with leiomyoma. So current status, according to NICE, they say that relugolix, estradiol, and norethistron acetate is recommended within its marketing authorization as an option for treating moderate to severe symptoms of uterine fibroids in adults of reproductive age group. Now coming to the androgens, danazol. Danazols are synthetic steroids, and clinical application was based on its anti-gonadotropin properties. Effects are mainly androgenic, together with moderate progesterogenic, anti-progesterogenic, and anti-estrogenic activity. Reduces the release of GnRH, FSH, and LH, alteration of normal growth process of ovarian follicle, and specific suppression of the endometrial growth and endometriosis. Produces amenorrhea, blockade of ovarian steroid production, blockade of GnRH release by the pituitary. But what is the current status of therapy? That despite benefits, the various undesirable side effects have been reported. And we all know that these are the virilizing symptoms like acne, hirsutism, weight gain, irritability, musculoskeletal pain, hot flushes. There is no evidence from RCT that says that the benefits of danazol outweigh its risks if you have to treat uterine fibroids. Now we come to the most important, that is the SPRMs, the selective progesterone receptor modulators. So first we will be talking about Yulipristol acetate. It reversibly blocks the progesterone receptors in its target tissues and downregulates expressions of angiogenic growth factors such as VEGF, increases the expression of matrix metalloproteinosis. We all are familiar with the dosage, 5 milligrams OD for 3 months, give a gap of 2 months, then again 3 months. But what happened that initially it was launched with much fanfare, and then it came in problem because DCGI suspended the license of the drug for the marketing of this drug in 2020, and based on the recommendation of European Medicine Agency. And the restrictions were due to risk of serious liver injury. And in fact, one patient even required liver transplantation, 18th February 2021. But now it has been again given permission, but it has to be used with caution. Liver function tests have to be done, and we have to be very careful. And after the completing the course of 3 months, give a gap of 2 months, again keep on doing the liver function test. And then when we are sure that we are not damaging the liver, we can go ahead. But it is quite effective in reducing the size of the fibroid. Now, what is the current status of this drug? Yulipristol acetate is effective in reducing bleeding, fibroid volume, and improving anemia. And while a single course of 3 months can be used preoperatively for delaying surgery, up to 4 consecutive courses with gaps of 2 to 2 months may be used as medical therapy. Now, baseline liver function tests are advised before starting Yulipristol, and treatment is deferred or suspended when the results are more than twice the upper limit of normal. This is followed by periodic monitoring of LFTs during and after the course of Yulipristol. Now, mifepristone, which is the most important SPRM which is being used nowadays. The mode of action, it is a progesterone receptor modulator with primarily antagonistic properties. It binds strongly to the endometrial progesterone receptors, minimally to estrogen receptors, and upregulates the androgen receptors. Reduction in size of fibroids with mifepristone might be due to direct effect in reducing the number of progesterone receptors. So a study was done, and the author's conclusion was that the short-term use of SPRMs resulted in improved quality of life, reduced menstrual bleeding, higher rates of amenorrhea than were seen with placebo. They may be effective treatment for women with symptomatic fibroids, and though SPRMs do cause endometrial changes, they cause endometrial thickening, but these are not in any way related to cancer, and they are not precancerous at all. That is, they are not endometrial hyperplasia. Now, in fertility and sterility, a meta-analysis was published of 11 RCTs with a total of 780 premenopausal women having leiomyomas. Treatment was mifepristone 2.5 to 25 milligrams for 3 to 6 months. It was found to be effective in reducing fibroid volume and the uterine volume and relieving the symptoms. And of course, no incidence of endometrial hyperplasia. So to conclude, we recommend daily treatment with mifepristone for 3 to 6 months as optimum clinical treatment for fibroids. And there is insufficient evidence of atypical endometrial hyperplasia. Now, what is the current status? Effective medical treatments for women with abnormal uterine bleeding associated with uterine fibroids include SPRMs. In women who present with acute bleeding associated with fibroids, conservative management with SPRMs can be given. So now we come to the SERMs. First is aromatase inhibitors. Aromatase inhibitors like letrozole and anastrozole also inhibit the aromatase enzyme, which catalyzes the conversion of androgenic substances into estrogens. So they block both ovarian and peripheral estrogen production within 1 day of treatment. Letrozole suppress the production of estrogens, particularly estrone and estradiol, compared to the baseline levels. Then we have the SERMs. They also display tissue-specific agonist-antagonist estrogenic actions, and most commonly used are tamoxifen, raloxifene. Raloxifene can be theoretically considered to be a good option for uterine fibroids. It only slightly affects the collagen biosynthesis. However, it significantly inhibits the collagen biosynthesis in the leiomyoma cells and exerts its action at the transcriptional level. But adverse effects are, it is not recommended for women with a prior history of DVT or embolus. Then LNG IUCD. We know this is a very good treatment option for intramural fibroids, and 85% of such women return to the normal bleeding within 3 months. 40% develop reversible amenorrhea at the end of 1.5 to 2 years. So if the patient wants to conserve her uterus and she has got intramural fibroids and she is not desirous of any further childbearing, then this LNG IUS is a very good option. Current status is that the LNG IUS can be used in women with intramural myomas who do not desire pregnancy in near term. Cabergoline. We all know cabergoline is used when the prolactin levels are raised. So depending on that same theory, it is used in fibroids also. And a group in Iran published a preliminary study in 2007 that favored the use of cabergoline as a medical treatment of fibroids, in which they reported a volume reduction of about 50% with 6 weeks of usage. The same group performed a subsequent study with GnRH agonists, and they found the same results. So probably it was because the GnRH, it was working as a GnRH agonist. That is why the effect on the uterine fibroids. Then some other drugs which are gaining importance are vitamin D. And we can see the importance of vitamin D in practically all the conditions nowadays. Then green tea extract, EGCG, It appears to block each stage of tumorogenesis by modulating the signaling pathways involved in cell proliferation, transformation, inflammation, oxidative stress, which are clearly involved in pathogenesis of various tumors, including uterine fibroids. Then we have the somatostatin analogs because they have found a role for growth factors such as IGF-1 and IGF-2. So that is why this role has also come up. Gene therapy, recent evidence suggests that fibroids develop as an overexpression of P14 gene. So now lots of conjectures are coming up about the genetic predisposition and the gene therapies which could go a long way in treating the fibroids medically. So to conclude, treatment of uterine fibroids must be individualized according to the presence or absence of symptoms, age, and desire for future fertility. Medical treatment should always be considered when counseling women on potential strategies for addressing the fibroid-related complaints. Evidence supports the efficacy of pharmacological agents for symptomatic control, and trial of medical treatment in selected and motivated patients may obviate the need for surgery. Thank you so much. And again, a request to everyone to please vote and support as I put my candidature for FOGSI president. Election year 2024. Thank you so much.
Thank you, Ranjana ji. Excellent and crisp talk as always. You have rightly covered about the pathophysiology, the risk factors, symptoms and all. But few things, what I think as my experience and few literature I want to hear quote is that we usually say that we should not treat asymptomatic myomas.
Yeah.
But I have an experience where there was a case which was operated by Dr. Chandravati madam for multiple myoma. And then she used to, consult me, and she was not, recovering. She was constantly having anemia, although there was no symptom. She was not having menorrhagia, but she was having constantly anemia. We are not able to correct it. Then when we got the ultrasound done, it was basically the pressure on the ureters that was causing the renal damage. And that is why she was not picking up with the anemia. So that was a, major one of the complications. So it is not always that you should always overlook asymptomatic. Always get it done. See the pressures which are not there on the ureters and the kidneys are not getting damaged. That's one of the experience that I have. So I wanted to share. The second one is we used to use a lot of Yulipristol initially when it was
Yeah. Yeah.
but then, it was like even one case can shaken you up. So there was one case where I could not bring down the LFT for 1 year almost. It was something between hundreds it used to be, and it was really alarming for us. And then that's the reason I stopped writing Yulipristol, and it's a little bit, we should be cautious. So
I never put it on paper at all.
yeah. So
now.
twice the normal, I think, limit. As soon as the LFT is rising, stop Yulipristol. Don't wait for twice the normal,
I mean, that is the...
Yeah. So mifepristone is a better choice, I suppose, and LNG IOFS, it is the patient, it suits well.
Yeah.
So that's the best part. And definitely mifepristone also gives the equal result, and it's quite safer because it has been seen that the endometrium doesn't show any atypia when you give mifepristone.
And another thing is also that if the patient slips into menopause, and if you must always monitor then also the size.
Yes.
Because suddenly if the size goes up, then immediately the thought of malignancy should come to your mind. Don't let the patient go ki acha now she slipped into menopause, it's fine.
दूसरा एक जो बहुत important pathology होती है, because fibroids are both estrogen and progesterone dependent, but mainly it is a progesterone. That is why we give more of a selective progesterone receptor modulators.
Yes.
But once you're giving for 3 months any SPRM and the patient is not responding, think of giving SERMs rather than, because she may be estrogen dominant fibroid.
Yeah.
That is why she's not responding to a progesterone. So that's one of the things that we need to keep in mind, that selective estrogen receptor modulators have some place somewhere when your progesterone receptor modulators are not acting. So that's, and you also talked about the recent, advances which are going on in fibroid management.
Yeah.
So thank you so much. I'll not take much of the time, but excellent talk as always. Special best wishes for your elections. And thank you so much, and high regards for Manju madam. Thank you, ma'am, for being here for this webinar. Thank you so much.
Yeah.
See,
Thank you so much.
Preeti, can I give an input here for Ranjana
Yeah,
ma'am's
yeah.
talk?
Yes.
Yeah.
Yes. Please.
Ranjana ma'am, really excellent talk. Very nice. Very crisp deliberation. And I think Preeti has summed it up very, very well that, you know, how to tailor the medical management of fibroid. It is good. What I have observed is that it is not very fruitful to chase the size of fibroid. It is better to focus on the symptoms. So if symptomatically she is better and she's improving in her general health and all, the size takes a little longer than what literature says. So it's better to look at clinical follow-up, and the size will happen in time, and that is what the patient also should understand. She should also realize that the size is secondary, symptoms are primary goal of therapy.
So,
The
Dr.
objective
Shobha,
should be relief
symptoms
of symptoms.
usually, but
Yeah.
by 3 months, the size should decrease.
Yes.
So the size should decrease by 3
It
months.
should,
3 months is a
but
target.
sometimes, you know,
But
Preeti,
by
what happens,
1 month,
the imaging
symptomatic.
doesn't catch it. Yeah.
Mm.
The way it decreases, the imaging is not very sure. You know, the size assessed will not be very accurate, actually. And it takes some time for them to
This is what
say
I'm
that,
saying,
okay,
but
the fibroid has
least,
decreased in size.
at least 3
And that
months.
Ask
causes
the
a lot of
general-
anxiety in the
See,
patient.
Dr. Shobha,
Yeah.
this is, if you see all this evidences and literature which have been done on Yulipristol and mifepristone, they talk about the size of the fibroid along with the symptoms. So symptoms and fibroid size go hand in hand. Maybe it will take some
Definitely.
time,
They
as you
go
said,
hand in
maybe 3
hand.
years. Yes.
No, I'm only trying to say is those who are projecting the medical management and kind of those who are wanting more and more prescriptions, they may say that, but as clinicians, for us, if clinical relief is there, we
Point,
must
yeah,
reassure the patient, even if the size is not reduced
So for
in
my,
that
for
stipulated
actually
time,
for
and wait
me,
for some
yeah,
more
yeah, I
time.
understood what you're saying,
Mm.
but my concern is,
Yeah.
what is the length of the medical? What is the duration? How long can you keep
3
that
to 6
patient on? 3 to 6 months. Then what
6
about
months.
after
6
that?
months. 6 months.
6
Suppose
months, yeah.
6 months. If you want to keep
Yeah.
prolong, if she's not having any problem, if you want to prolong medical medication, can you? Then in that case, LNGIS definitely has a better, you can put that and you can put it for 5 years. So there is another question
Correct.
Dr. Preeti Sahai has asked. If the size is more than 4 centimeters and 2 to 3 in number, usually medical management is not effective. This is what her concern is. So
Does
Dr.
she have, does the patient have any symptoms? That
No.
is also because
Yeah.
sometimes what happens if it's an adolescent girl in her teens, and by chance if an ultrasound is done for something else and they find small fibroids, the mother practically gets hysterical. What to do? The patient is symptomless. Then it is just better to counsel the patient and tell them wait and watch. Sometimes they regress themselves also. And
Yeah.
the patient is so young, 13, 14, and they get an ultrasound done and they find small fibroids, and then they get upset ki gaant hai, ab operation karwana padega. So they have to be counseled, and you can't give these medications also
So I think
so early
you
on.
rightly said if there are 2-3 fibroids, 3-4 centimeters, 2-3 centimeters, you need not to put them on any medication.
Yeah, we can just wait and watch first,
Yeah,
na?
yeah. Thank you so
Dr.
much.
There is
Manju,
another,
Dr.
there is
Manju,
another question in the question.
हाँ, बोलो.
That somebody is asking what is the dose and frequency of mifepristone and how long it should be given.
10 to 25 milligrams is the dose, and it has to be given once daily for 3 to 6 months. We can even give it till 1 year.
Yes.
And the cycle will not remain normal. It becomes irregular, and sometimes there are periods of amenorrhea also, which should actually not matter much to the patient. We have to counsel the patient when we start.
Okay,
Okay.
thank you, ma'am. Now,
Thank you so
would
much.
like
Now we
to
can
know
move.
the expert opinion of Dr. Manju Varma, ma'am.
Well, thank you very much, Chitra. I would like to start my giving my comment that I want every one of you to vote and support Dr. Ranjana Khanna for the post of president and Dr. Preeti Kumar for the post of vice president. यूपी किसी तरह से नींद से जागा है, कृपा करके उसकी नींद को बरकरार को खत्म करके जागिए हमको यूपी से चाहिए. तो मैं आप सब I simply want you people to vote and support, and I would like to congratulate Dr. Ranjana Khanna. She has given such a fine details of everything is there that she can, covered almost all the things, starting from the history to the indications, what time, whom to be given, then how to classify hormonal and non-hormonal. And then here I would like simply want to say that ILNG IUS system should only be used in patients whose uterine cavity is not distorted.
Yes.
Because if the uterine cavity is distorted, then LNG IUCD are likely to cause symptoms of pain and spasmodic pain. So it is the three. Somebody said in the comment, 3 intramural totally, and whatever may be the thing, that you have to see that the uterine cavity is not distorted. That is only one thing that I would like to say. And in the end, I would like to say nowadays that the treatment recommended is basically the sperm. And mifepristone, previously known as RU486, isn't it? And a long trial of this drug has been done. CDRI Lucknow was the place from where it started. So we have a very long experience of mifepristone, and that it cannot be given for years together. So that is why you say that this is supposed to be the best treatment nowadays. Of course, other things are there. And here I would like to want to say something about the diagnosis about fibromyomas. Is it being tried or no?
For bleeding control, yes.
It has been tried.
For
But
bleeding control, it has been tried, but otherwise,
studies are available
role.
as yet.
No
So
role.
please don't start it, because I have seen people writing it. That's what I'm saying. Because you might have been caught in the court of law. So please don't, by thinking yourself, you think you can do it, and non-harmful, very good. If something happens, then I think it's not right. So I would like to again say vote and support Ranjana and Preeti.
Thank you so much, Ranjana ma'am, for such a comprehensive talk, and everyone for such interactive session. Now for the next session, I hand over the proceedings to Dr. Uma Jaiswal. Dr. Uma is Director of Shakuntala Hospital, and she is Honorary Secretary of Allahabad Obs Gyn Society. So for next session, over to you, Uma.
Thank you, Chitra di. Ranjana ma'am is a wonderful talk, very crisp and very clear. Good evening, everyone, and I welcome everyone on the faculties on the board. My second chairperson is Dr. Abhilasha Chaturvedi. Ma'am, she is director of Abhilasha Hospital, and she is infertility and first IVF specialist of Allahabad city. She has gave first IVF baby in 23rd November 2000, and she introduced ultrasound in Allahabad in 1985. She is past president AOGS, Rotary Allahabad, AMA, immediate past president UPIMA. This talk is a very important topic. We usually come across knowingly or unknowingly during our cases. There is a myoma. So it's very important. Dr. Shobha and Goody, she is talking on cesarean myomectomy. I request Dr. Abhilasha ma'am, please introduce her.
So my duty is, I'm going to take the duty of Dr. Anuradha Khanna also.
Both the chairpersons.
Yes.
So Dr. Shobha Goody, I have met her in Allahabad when she came for her conference. And she's a past president of Bengaluru Obstetrics and Gynecological Society. She has got so many positions, and I don't think it is fair to waste time on describing everything. She is a peer reviewer of Jogi. She is a teacher of DNB also.
Thank you. Thank you for remembering my visit to Allahabad during the obstetric diagnosis.
Yeah. We had a photograph also.
And of course,
it was Khanna.
And I remember you.
When the conference was there. You man. your conference.
Correct, ma'am.
Okay.
Correct. And I remember you as the mother of Dr. Tanya, who really supported my committee work with a very good Facebook programs, and she's really brilliant. And she is so because of you, Dr. Abhilasha.
Oh,
You
good.
have
good,
groomed
good.
her so very well. And I really thank Dr. Ranjana for creating this space and this information exchange on fibroid. I'm very grateful to the kind words by Dr. Manju Varma, and I'm very happy to meet all of you today and my dear friend Preeti. And I pray to God and I seek His blessings for the two of you, the twins from UP, the sisters from UP, Dr. Ranjana Khanna, and the younger one and the dynamite, Dr. Preeti Kumar, that both of you should get the maximum votes. खाली जीतेंगे नहीं, maximum votes से जीतेंगे, है ना प्रीति जी? So that should be the spirit of going forward. However, apart from the fact that we enjoy ourselves so much when we are together on webinar, we have some primary duty to deliver the scientific information that we have been given. So in a very few slides, because I don't think that this subject is unfamiliar to any of us today, most of us would have removed that occasional fibroid that we see during the cesarean section, and most of the time the patient does well also. But nevertheless, it's very important to stand informed as to what we are doing. Is it right? What may be the correct way of doing it? How much scientific evidence supports this? And is there really a need in the light of the new therapies emerging? Is there really a need to extend that cesarean section into a major surgery? So the story of cesarean myomectomy actually started in the last century, and it is, I think, it was around it was around 1913 that Dr. Victor Bonney, who was the proponent of myomectomy, the father of myomectomy, in fact, initially condemned the surgery, but finally started doing it, and then at last reported that along with his cesarean section. Now, this is an excerpt of the cesarean section which he did first, but subsequently he also put a similar publication of myomectomy. And initially he condemned, but when his pupils started performing the occasional myomectomy with cesarean section, he also fell in line and he also has published. I could not get that one, so I just put that one for context. Now, since then, over the last few decades, this surgery has seen a lot of acceptance. And in the last 10 years, if we can relate to this particular systematic review of special value, because it happens to be from India, because it has covered a 10-year review and quite a few studies, and it declares that there is a true shift from contraindication to indication for cesarean myomectomy. So what we were taught as undergraduates and postgraduates, never touch a fibroid during cesarean section, has actually made a turnaround and allowed us to remove few fibroids for the benefit of the mother. Now, existing evidence from present systematic review of observational studies versus cesarean section alone, of cesarean myomectomy versus cesarean alone, actually indicates no difference in the incidence of hemorrhage. The statistically significant increase in odds of blood transfusion, however, is a high quality evidence, and it is acceptable because whenever there is a myomectomy, whether in pregnant or non-pregnant, blood transfusion can be accepted. A statistically significant but clinically insignificant reduction in decrease in hemoglobin is quite acceptable, but significant increase in operative time is what the surgeon should be mindful of and be prepared for. So then, is it a safe procedure? Can be answered by studies like this. Though it is retrospective, it did show that it is safe. And even if the myomas are larger than 5 centimeters, and equivalent results to cesarean section alone in a uterus with a fibroid, and the reduction in hemoglobin level, the rate of complications, and the number of transfusions were actually similar in both the cesarean section and the cesarean myomectomy group. and that is a good, published in 2017. The similar thing we see again, this study which says more light and fewer shadows in favor of cesarean myomectomy, published in the journal Obstetrics and Gynec, again 2017. The authors conducted a literature review based on the benefits and the outcome of cesarean myomectomy. So this was an outcome-related study which was published, and then it showed that the data on long-term outcome of cesarean myomectomy in women are still lacking. However, because it is a rare surgery, such studies will take much time to come to light. But there are relevant articles in this study, and it can be sourced. It is called More Light and Fewer Shadows, but ultimately it also speaks in favor of doing a cesarean myomectomy. So now Dr. Ranjana very nicely pointed out HMB related to fibroids. But if you look at fibroids in pregnancy, it is not a rare tumor at all. It is around 1.6 to maybe 5%. And 42% of the large fibroids, more than 5 centimeters, can be actually detected in the pregnant uterus. They behave differentially during pregnancy. Some will grow. The larger ones will actually grow, and they will almost grow to their full potential in the first half or first few months of pregnancy. Those who are not likely to grow will more likely flatten out and will not give us any trouble. We all know that fibroids in pregnancy will cause certain complications like this. I need not list it out, but you can see that there is higher propensity for prematurity and hemorrhage and fetal growth restriction, even malpresentation, labor dystocia, right? And all these are reasons why women with fibroids will find themselves in the theater for a cesarean section. And that is when we have to decide whether we need to remove the myomas along with the fibroid. And if we have indeed looked at the possibility of myomectomy, then we need to remember that a very good consent has to be taken, and women should be informed about the pros and cons. I'll come to it in a minute. This is a slide which speaks about dysfunctional labor in fibroid present in the uterus at the time of delivery, and there are higher rates of tachysystole also in case induction is used. The reasons for cesarean delivery are therefore very much found in fibroids in pregnancy, especially when they are located in the lower uterine segment. And systematic reviews do say that there are 3 to 4 times higher risk of cesarean delivery. And the risk is more due to malpresentation, dysfunctional labor, sometimes obstruction, and even placental abruption, especially if the placentation has happened on the myoma bed. Most of these studies were biased in their selection of cases, and therefore we still stand at the crossroads that whether this directly causes, whether there is a causal association between these complications and the myoma, but nevertheless, strong associations are there enough to plan for a cesarean. For example, in a fibroid like this, which is sitting in the lower segment close to the cervix, almost involving part of the cervix, where is the chance of a vaginal birth? We have to plan for a cesarean. So when we are faced with a myoma at the time of cesarean, or when we look at it in the ultrasound in the 2nd and 3rd trimester, we must think of all these options, whether we are going to leave it completely or we leave it doing a uterine artery bilateral ligation following the delivery of the baby. If we encounter hemorrhage, remove pedunculated fibroids only should be the policy. Remove pedunculated anterior, subserous, or lower segment fibroids should be the policy. Remove all anterior uterine fibroids or remove all fibroid. What should be our policy? So what comes across is selective removal of fibroids rather than routine removal. So when you are faced with such a situation, you do a selective removal of fibroids, and all fibroids need not be removed. Few fibroids which are likely to create trouble in future or more strategically located can be removed. So in favor of selective removal of fibroids, it is a safe procedure in safe hands. Principles of myomectomy during pregnancies, the steps are almost similar to a non-pregnant, but The hemostatic mechanisms and the methods to be adopted are slightly different. Experience is needed. Good equipment, tertiary care is better. Better anesthesia, availability of blood and component is essential. Full consent, informed consent of the patient is essential. Selection of patients according to site and size of myoma. That means a very thorough mapping of the fibroid, ultrasound mapping of the fibroid. Rarely MRI can be used to define the need for myomectomy. Well, if you select patients well, then it will reduce the blood loss and consequent anemia. Techniques that reduce the blood loss should be, the operator should be familiar with that. Tourniquet, the electrocautery, uterine artery ligation, even uterine artery embolization, and high oxytocin flow therapy. All this should be kept in mind. When to do cesarean myomectomy and when not to do cesarean myomectomy. There can be few broad guidelines, but the main judgment for whether to do or not to do is the hands of the surgeon. However good the imaging has been, the final picture will emerge only once you have opened. So the main challenge actually will be in what kind of incision to give. Now, prior ultrasound mapping is best. Typically, only those which will need removal even after pregnancy and puerperium. These are the fibroids which should be removed. That means basically you are trying to avoid a second surgery for the woman. Fibroids in the lower segment, especially if they are in the way of delivery or in the way of closure of the uterine incision, deserve removal. Those who are on the anterior wall of the uterus are safer to remove and cause less adhesions. Subserosal pedunculated, of course, can be removed. When not to do, if the fibroid is directly under the placenta site, removal can cause more hemorrhage. If they are fundal, intramural, large in size, they are usually a bloody thing to remove. More hemorrhage in such cases. If they are cornual, they can disturb the anatomy of the tube if we are trying to remove. If they are in the lateral ward, they are close to the uterine vessel, the complex, and that is where the blood supply can get affected and more bleeding is possible. In the broad ligament, it's better not to do because these are rarely symptomatic. And vascular surface, on the surface or in the vicinity, if there are very dense vasculature, then also it's better not to attempt. Because please remember that whenever there is torrential hemorrhage along with myomectomy, a hysterectomy also can become a life-saving thing, which one should not find ourselves in that situation. The logic, so because many practitioners can have a differing opinion and say, why do? Especially after listening to Ranjana ma'am's talk, they might say, okay, well, we can put her on medical management following the cesarean section. So many medications are available. Why do the surgery at the time of cesarean? So what is the logic? Okay, so the first logic is that you can avoid a second operation. Secondly, that will save her cost. Thirdly, it will prevent the risk of myoma-related complications in subsequent pregnancies. If you are not removing it in the interval period, then it will accelerate puerperal involution. Removing the myoma will give better puerperium, better recovery for her, and the subsequent cycles are better. And most importantly, studies have now shown that it is safe. And to say, if you can keep in mind the uterine contractility, the anatomical localization, that means you do a very careful patient and fibroid selection. The number and the diameter of myomas and the presence of large vascular structures, if you take into account, it can remain safe. And the fact that there are better planes in pregnancy, the pseudocapsule is kind of loosened in pregnancy, the uterine contractility helps in hemostasis better. Hypercoagulability related to pregnancy is also helping in hemostasis. All these factors will encourage you to perform. And the one important thing that one needs to remember is the actual technique of removing the myoma is not very different than in a non-pregnant, in an open case. And therefore, this does not require intensive training or doesn't have a very long learning curve. So that is something important that ops and gynecologists, well-trained, good, well-experienced, can perform this. As far as the consent is concerned, there can be some skill involved in counseling while taking the consent. So probably this is where experience counts more than during surgery. Informed consent is important. For cesarean section in women with large or cervical fibroids or even otherwise cesarean myomectomy, must include the knowledge of the risk of hysterectomy. So the woman should understand that. Admission to intensive care may be possible, and modified skin incisions should be told to them earlier, and blood and component transfusions must also be kept informed. The technique of planning the incision, I spoke about it a little earlier. I thought that I will again tell you here that the uterine incision should be made away from the fibroid as far as possible, because if it is including the bed of the fibroid, then it is possible that there is more bleeding even before the delivery of the fetus, and that may endanger the fetus as well. You must correct the dextro rotation, because very often a heavy uterus tends to get axial displacement. So better to correct dextro rotation, or levo rotation, whatever is there, and get the correct anatomy. So identify all the landmarks, check out the peritoneum, the round ligament, etc., so that the UV fold, and then plan the surgery. So it's better not to be in a hurry. Plan the surgery. Have another senior colleague who can assist you in this case. Two consultants are better. Kindly don't attempt surgery with a junior postgraduate or during emergency hours, etc. Always better to have a bright early morning OT for this case. Prefer always to deliver the baby first. Myomectomy should be performed after cesarean section. Only exception may be where delivery of the baby is not possible without removal of fibroid, and this can be occasionally done, and the fibroid may have to be removed first if it is bang on the lower segment. If the size of the fibroid on the lower segment is very, very large, like a cervical fibroid, then this is one of the indications for a classical cesarean section. So you really have to plan the incision much in advance wherever there is a very large fibroid. The technique, I have already said that it may not be very different. So the lower segment Kerr incision, after extraction of the baby and the placenta, the myomectomy is performed. Fibroids on the anterior surface near the fundus can be removed via subfundal transverse incision. So that means that a separate incision can be given for removal of an high anterior surface fibroid. Fibroids near the cesarean section actually can be enucleated via the same incision, preferably after fetal extraction. And a linear incision made on the fibroid using bipolar cautery, electrocautery, enucleation, and then suturing in 2 layers. And then suturing in 2 layers, 1-0 vicryl, all that stuff says 1-0 vicryl and then 2-0 vicryl to make it simpler. And then bimanual uterine compression. AMTSL should be meticulously followed, whatever is your protocol. Intravenous oxytocin infusions should be carried out, and later on there has to be thromboprophylaxis. Okay, fine. So how to achieve hemostasis? Unfortunately, the case which I did, I wanted to upload the pictures here to show the triple tourniquet, but somehow I could not upload the pictures. I'm sorry, and I could not get an equivalent from the net. So we'll have to do without that. So what should be done are 2 or 3 things. Pharmacological interventions are also necessary. The vasopressin has got missed out. I should have put vasopressin also here. So I'll tell instead, okay? So it is possible to inject dilute oxytocin into the myoma pseudo capsule in case vasopressin is not available, but the ideal one is vasopressin. So the vasopressin 1 ml contains 20 units, and we can dilute it into 50 ml of saline, normal saline, or 100 ml. Maximum dilution is up to 100 ml. Inform the anesthetist that you are going to inject, and then infiltrate it subcapsular as far as you can see the myoma, as far as you can see the surface of myoma, and even in a little bit in the surrounding myometrium. Some, even if they are planning to remove 1 or more myomas, they give it in the fundus of the uterus, just like you would give in the fundus of the uterus at the time of a laparoscopic myomectomy. So it is possible to give up to 50 to 100 ml of diluted vasopressin, 20 units of 1 ml of vasopressin diluted like this. There are other techniques which are being followed, and they can be done in combination. So this pharmacological prevention can be combined with purse string suture at the base, especially if there is a small base like a pedunculated fibroid, a combination of tourniquet and electrosurgery, oxytocin infusion, intravenous should be on flow, Dissection can be followed with electrocautery. I usually keep both bipolar and monopolar with me. Uterine artery ligation is an option, especially if you find more hemorrhage. You can quickly do uterine artery occlusion, and thanks to our advanced management of PPH today, we are all a little adept at ligating uterine vessels. Then selective uterine devascularization is also an option in select cases, but it requires a lot of preparation and additional help, and also a special OT table which is enabled with a C-arm, etc. So that infrastructure requirement is very high for uterine artery embolization. But we can do manually selective uterine devascularization by applying sutures. The combination of bilateral ascending uterine artery ligation and the tourniquet will really help us. So the triple tourniquet technique says that you can apply a tourniquet around the uterine vessels at the level of the internal os of the cervix. The lower part of the lower uterine segment also will work well, provided there are no fibroids situated in that area. This tourniquet will work well. Any tourniquet can be on for 20 minutes without any danger of ischemia to the organ. And if you are concerned, usually the enucleation gets done by this time. And during the second layer of the closure, we always prefer the tourniquet to get loosened, because we don't want to leave any bleeders in the dead space behind. So we want to be very sure that we have taken all the bleeders, and that is why we need to release the tourniquet by the time we start closing almost, the second layer. So that is the other thing. This tourniquet can be a Foley's catheter, can be a Malakoff's catheter, but what I have used, and I have found it very useful because it is a little more stiff than the other two catheters, is a disposable suction plastic tube or a plastic cannula number 10 that gives the same caliber as a good sized Foley's, and it is also equally atraumatic. And it needs to be brought out from avascular area of the broad ligament of both sides to the front, needs to be twisted, one end or the other end, and then an artery clamp should be applied to the twisted ends of this so that it stays in place. The infundibulopelvic ligaments of both the sides can be subjected also to tourniquet, especially when you are dealing with fibroid in the upper uterine segment. So these tourniquets I have used at times this infant feeding tube, a number 6 infant feeding tube on both the sides. The technique is the same. We have to create a vascular window in the mesosalpinx particularly, and then we take a lateral knot. We can again twist it and put small hemostatic clamps there and keep releasing it in between. So sometimes it is useful to have one person in charge of the tourniquet so that they can judge 20 minutes of time and release. But most often this kind of micromanagement is not necessary, and we can quickly remove 1 or 2 fibroids. So just in case, we should never forget that tourniquets are really invaluable. Now, what is new in cesarean myomectomy. What is new is endometrial myomectomy. May not be very new for a non-pregnant, approach in a non-pregnant woman, but definitely in cesarean section, very few have been performed so far, and it is very useful to know because sometimes we find that there is a myoma in the posterior surface of the uterus, which is just bulging through the mucosa. That means it's a submucosal fibroid, not yet become a polyp, but it is a fibroid polyp, but it is a submucose, maybe FIGO stage 2 or something like that, but it is bulging into the endometrium. So when you deliver the baby in the placenta, you can identify this bulge on the posterior surface. We can easily give an incision with an electrocautery on the endometrium and enucleate the fibroid, and then neatly suture the endometrium over there. And this concern about intrauterine adhesions in subsequent years, in subsequent months, which will come in the way of future fertility, are ill-founded because follow-up hysteroscopies have always found that these adhesions are quite minimal. And, that is the main reason is that the uterus actually involutes enough to make this scarring on the endometrium into a very small area. So it becomes a very small area of scarring, which can, and healthy endometrium can grow over it. And even if adhesions form, they are minimal and then can be lysed easily in case they cause infertility. So let me say a few concluding words, because there is not more than this that we can speak unless we can show a surgical video, which unfortunately I do not have. Now, all of us today are looking at videos online all the time. So it's not productive to take the time of the webinar into that. Now, fibroids are actually common tumors. And if you ask me, I have found fibroids more often in fertile rather than in infertile women. And we encounter them more often in pregnancy today. The majority do not change their size during pregnancy. And if they are large, they will remain like that more often. 1/3 may grow in the first trimester. Size and location appear to be risk factors for pregnancy complication, of course. More than 5 centimeter retroplacental location, distortion of cavity associated with increased risk of obstetric complications, carefully planned antepartum myomectomy in selected cases in an appropriately low morbidity option. Now, this antepartum myomectomy and allowing the pregnancy to continue is, I must say, it feels to me like experimental. That is the reason I did not speak about it. But there is good amount of cases today reported. But pregnancy outcomes are not very favorable. Cesarean delivery is performed for standard obstetric indications only, and seldom because of fibroid. It's only if there is an obstruction to the birth canal, then fibroid is the indication. Myomectomy during cesarean section does not increase complication or transfusion rates and appears to be a safe procedure, but it has to be done in that meticulous fashion, has to be planned, and should not be attempted if you're not kind of prepared well and you chance encounter of myoma. Better to leave it alone. Every effort should be made to avoid cutting through the fibroids of cesarean delivery, because then we don't get the correct plane. And risk-benefit ratio of cesarean myomectomy should be re-evaluated in the new century, given the increasing patient age, incidence of myoma in pregnancy, and the wide use of assisted reproductive techniques. We have not yet kind of said the last word about the risk-benefit ratio, but nevertheless, it appears to be a safe option in carefully selected cases. Thank you very much for the time given to me. Thanks a lot.
And thanks, Dr. Shobha. You have covered it so well. In spite of appreciating your lecture, I will like to put a question. Yesterday only, I have seen a patient, 38 years old lady, 7 years of infertility. She is 8 weeks pregnant. And she did not do the myomectomy because somebody said that before doing the myomectomy, you will have to freeze your embryos. So she did not do the myomectomy in spite of knowing about this fibroid. And she conceived spontaneously. It is a 10 centimeter fibroid with 8 weeks pregnancy. It's a fundal fibroid. She came to me. What should I do? Do you recommend antenatal myomectomy?
No, nothing to be done. Supportive treatment for the pregnancy, and just keep counseling. Maybe 1 or 2 extra ultrasounds may be necessary to monitor.
Yeah.
Look for symptoms of degeneration and counsel them about the possibility of, but since this is fundal fibroids actually behave quite well. They behave quite well during pregnancy.
But I don't think with this big fibroid, which is going to grow during pregnancy in size, will allow her to go up to.
It will allow.
They do go. They do go.
They do go to
They
term.
do go because it is. Yeah, they do go to term because it is observed that somehow.
Real temptation to
Pardon?
do antenatal. There is a real temptation.
Yeah, it is very tempting. It is because see, unfortunately, God has given us only 2 organs to operate on, and maybe only 2 or 3 tumors to operate on. So my point is that we must only operate and not give it off to the radiologist and not, and so, but at the correct time. So this is not the time for this woman.
But
the case
Shobha,
that I
one
was
thing I
telling you where
wanted
I
to,
did a myomectomy also.
Shobha, one thing I wanted to share, that you said don't go through the fibroid, right? But there was this patient of mine who came in emergency, and there was an anterior wall fibroid which was covering, it was an intramural fibroid, and it was covering practically the whole of the anterior surface. And if I had to miss that fibroid and take out the baby, it had to be a fundal incision. And there were very few relatives, and I was caught in a very tricky situation because the hemoglobin was 9 point something, and it was an emergency. She was in obstructed. So I cut through the fibroid, took out the baby, and believe me, I had no problem in restitching it. I did not dare to take out the myoma. I said, what the hell? There are no attendants, no blood arrangement, patient is anemic. Why should I land myself into hot soup? So I just cut through the fibroid and wonder of wonders. Post-operative, after 1.5 months, she got an ultrasound done. Fibroid had regressed dramatically. I was thinking that maybe because I had
Correct. That
suture,
is the
because I had
that
sutured
is the other
blood
logic which
supply, I
people
must have
give.
cut
Correct.
off. So you can easily go
Sometimes,
through.
yeah, correct. Sometimes they are adenomyomas also. They are
Yeah.
not always fibroids. Sometimes we find
So
adenomyomas.
that was a fibroid. I could see
That was
the
a fibroid. Okay.
appearing. Yeah, 100%.
Okay. 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 Okay.
Very
What
complicated.
So questions, some questions are there.
Hmm.
Shika Maurya has asked, large myoma, 7 centimeter, lower segment anteriorly. Where should we give the incision for delivery? That is what I am trying to say, that the final decision comes only after opening, because then you have to check how much of the lower segment is free of myoma.
Exactly.
Where is the bladder? Where are the broad ligaments? Where are the vessels? Is there enough space? So I will describe to you one case which I had where the fetal head was sitting above the level of the fibroid. The fibroid was in the lower segment on the right side, and we found space below the fibroid, about maybe 2 to 3 centimeters, but we found some space on the left side.
Yeah,
Now, this
sometimes you do
patient's
have to go laterally.
ultrasound, yes, ma'am. This patient's ultrasound has clearly showed that there is cord below the head. Cord had come below the head. That also can happen because, if there is rupture of membrane, there is cord prolapse. That's why we scheduled it little quickly the very next day. Now, when we gave the incision, we planned it like a J-shaped. We went on the lower segment, and on the left side, we took a turn parallel to the fibroid so that we get enough space, because on the right side, there was not enough space. So what I'm trying to say is you can plan an incision by the side of the fibroid, and later on we found that once the baby had, of course the delivery of the baby was difficult, and we used vacuum on the head because it was coming up to the incision, so we used a vacuum and it came out. Now, having said that, once we removed it, we found that it was possible to enucleate the myoma through the right edge of the incision. And it all came okay, it was nice. And we were able to do a decent repair of that incision. The right side was a little irregular, but it came out okay. So once we open only, we will know. So that's why I'm saying that it is important to have 2 heads at the time, and you should have help so that, we don't panic and we do a good job. Yeah. That is the answer. So if you're asking whether you need to take a upper segment, so it will be, if you have gone through pen and steel, then upper segment will not be possible. So you will have to go for something like a J-shaped incision, or maybe lower segment vertical, and you will have to manage. You will have to manage, right? Or else, if you feel that it is large enough, then you should have planned for a vertical incision and an upper segment delivery, which is acceptable. It is acceptable in such a case. Nobody can question us for the classical cesarean if we do when a large myoma is present in the lower segment. That is your surgical decision. Yeah.
But subsequent pregnancy will be very risky.
Definitely. We have to immediately alert them that this is what has happened. And I think medico-legally, it will be great to have a recording or pictures of what you find and then share it to them. that, see, this is what has happened. Because in this era of all these digital communications, why not, have documentation that you have done the right thing with good thought? Because believe me or not, they are anyway going to show it to somebody else and ask, isne theek kiya ki nahi kiya? So it is good to have all that in your favor. But see that you have, good planning and you do everything good possible for the patient. If our intention is good, I think we will be safe.
Yeah.
Patient.
And in that case, the patient fared very well. And then she conceived again after 2-3 years, and there was no problem.
Yes. Yeah. My patient of cesarean myomectomy also, madam, had a repeat cesarean with me. And also later on, she had a enough size uterus to go for an LNG IUS as a contraceptive for several years. And recently she attained menopause, came and got it removed. So it goes like that. She was already 37 when she had her first child, I think.
Yeah.
So it goes like that sometimes. Yeah.
I think it depends on patient to patient, and sometimes if you are caught unawares, then at the spur of the moment, the decision should be taken carefully and wisely.
And the help available.
Yes. We can call for help, madam. If we come across anything like this, we can call for help. Yeah. Nowadays, there is a lot of faith in having group practice, or at least having, friends forming strong groups so that we can call each other. And then I am in an institution. For me, there is a team, but otherwise, always have, a buddy system or a friend system.
Thank you, ma'am.
You would want to say something?
Ma'am.
Yeah,
Now
I would like
request
Madam,
Professor Manju Varma, ma'am, please give your expert comment.
I've asked her to give.
Shobha, Dr. Shobha, I must say that you have taken every minute details in such clear way. And very rightly, in our times also, we used to say, whenever doing a myomectomy, whether, why you have to arrange the blood. And be careful if the fibroid, the placenta is attached to the bed of the fibromyoma. So rightly explain everything, what should be done, what should not be done. And here, as Ranjana said, I would like to say one thing. One case of mine, I was operating, she came in emergency. And, those were the times in 1972, the ultrasound was not available everywhere like that. And when I opened, I found a central cervical fibromyoma. I had no option. I called my Professor Shore, and he said, no, go through. And he made me do it through the cervical canal. He said, give a vertical incision. If the head is not coming out, at least you will be able to expand it upwards. So I just did it. And since then, I remember I said that the fibrom. And the other case I would like to quote over here, there is a patient of mine who has got 22 fibromyomas in her uterus, and she was pregnant. So the God is great. Those were the times when the facilities were not available. The diagnosis was not so easy. Now we can do the diagnosis, though. So there are so many things which we have to leave to the God also. That even when you do, the chances are that you are doing for the good, and yet the result may not be very good. And the other thing is you are doing it. All those things, I don't want to explain what happens at the level of surgery, and the things come out to be very nice. The other thing I would like you to comment, Dr. Shobha, is it right to do a myomectomy first, if you can do, and then deliver the baby?
Yeah, most of the review of literature points towards the fact that it's better to extract the baby first, because once we disturb the myoma, we never know kind of how much blood will be lost. And then the baby may suffer because of that, because we don't know how much of circulation, where it will get impeded. So it's better to deliver the baby first. The only exception is when there is a reasonable size myoma sitting on the lower segment, bang in the place of our incision. And sometimes we have to enucleate, even though if we don't kind of remove it completely, we may have to enucleate, hold it up, and then, give an incision, and then do the final myoma bed repair, etc. later on. So some tactic like that may have to be used in order to gain space for the incision. We may have to lift the myoma off its bed at least partially in order to give an incision. That is the only place where I see Otherwise, it's better to do a safe cesarean, close the uterine incision, and then proceed with the myomectomy. That is the correct order of things.
Yes.
And
Now
just
we
remember
have
about this endomyometrial. Yeah.
Thank you,
Thank
Manju
you.
ma'am, for an expert comment and very elaborative and informative talk by Shobha ma'am. It was a wonderful and
Thank you.
experienced talk.
So now we can
Ma'am,
say
I want
one
to
thing
ask
with
one
this,
thing.
that I want to say one thing, that you can't always blame the fibroids for infertility. So
Yeah.
now Dr. Sheela is going to tell us about that angle, when we can actually blame them for the infertility.
मैम मेरा एक कंसेंट है ये कि अगर हमारा पेशेंट, हमें मालूम नहीं है उसका फाइब्रॉइड है, वो इमरजेंसी में आता है और हमारे पास फाइब्रॉइड निकालने का कंसेंट नहीं है, क्योंकि आजकल कानून की किताब बहुत बता रही है पहले से कंसेंट होने चाहिए, नहीं तो ओटी में आप इमरजेंसी करेंगे तो आपको कंसेंट का वो मतलब नहीं रहता है, तो हम क्या करें उस सिचुएशन में?
बच्चा निकाल के
Cesarean
teaser
myomectomy
करके
should
छोड़ दो.
always be a
Only
planned
recording.
surgery. हाँ.
हमारे
Leave
स्कार
it.
पे अगर आ रहा है, हम मतलब जहाँ
Leave
इंसिजन
it.
दे रहे हैं वहीं आ रहा है, तो हम क्या करें?
I cut through the fibroid, took out the baby, sutured it, and shifted the
Sutured it.
patient, hale and hearty.
Yes.
Nothing
Yes, ma'am.
happened.
Yes. Thank you for
Because
the
the
great
attendants
ma'am.
were not there. There was only one or two attendant not willing to arrange blood. Hemoglobin was less. Why should I put my neck in the rooster unnecessarily?
Yes.
Safe
Yes.
practice is the best.
That is
best
that is the information.
Yes.
Because
You don't have to be extra bold for anything.
Yes, ma'am. Thank you so much for a great discussion, and inputs are very good. Now I hand over my next session to Dr. Parul Khanna. She is my co-convener. She is IVF specialist and IVF consultant at Nova Southern IVF Center, Rajouri Garden, Delhi. She is our AOGS member. And she is the daughter-in-law of Dr. Ranjana Khanna ma'am. Now I hand over the session to Dr. Parul Khanna.
Thank you, ma'am. We now move on to our final session, which is a talk on correlation of fibroids and infertility. Ma'am is professor and unit head, medical education unit coordinator, Rajashri Medical Research Institute, Bareilly, founder and president of Society of Menstrual Disorders and Hygiene Management, Node Zone Coordinator, National SR, YTP Committee FOGSI, Clinical Secretary of GNOGS. She is also Chief Editor of Journal of Reproductive and Menstrual Sciences, and with various awards to her honor by WHO, Award of Excellence in Promotion by Gramalaya, Ministry of SDW 2019. I welcome you, ma'am.
So thank you so much, Ranjana ma'am. And good evening, Manju ma'am, all respected seniors, and a great good evening and hello to Seema Pandey ma'am, my favorite again. So this is a talk which had to be delivered by Dr. Neharika. So I'm just substituting her, and it will be great to talk about fibroids and infertility, especially after we had wonderful inputs by our respective seniors. We just heard Manju Varma ma'am saying, God is great. We see so many fibroids. हो जाता है, निकल जाता है. So on one hand, we are talking about myomectomy at the time of cesarean. And on the other hand, we see lots and lots of patients taking multitudes of treatment for infertility, which they presume is arising due to fibroids in their uteri. So let us dissect these facts. Obviously, they are the commonest uterine tumors in reproductive age group. Thus, patients having infertility and subfertility will be having some amount of this incidence by default. Fibroids, when talked about where they are placed, 99% of them are in the uterine body: corporeal, interstitial, submucous, and subserous. Cervical fibroids accounting for a less percentage of these fibroids, whereas extrauterine like extragenital, parasitic fibroids and others take a very, very small chunk of this proportion. So what are the kinds of fibroids and how we as fertility specialists should be looking into it? The European Society of Hysteroscopy gave this classification of submucous fibroid, which are distorting uterine cavity, because these are the important, I'll call them villains, which impair fertility in these patients. So type 0 is pedunculated without intramural extension. Type 1 is sessile with intramural extension to the tune of less than 50%. Type 2 are the sessile ones with intramural extension more than 50%. Again, type 2 intramural fibroid not distorting the cavity and less than 50% protrusion into the serosal surface, and subserosal are more than 50% when it is protruding out of the serosal surface, which are again sessile or maybe pedunculated. So this is our favorite classification given by FIGO. And this sub-classification system has not only eased out our understanding of management of fibroids, but we are able to explain the patients also in a better way. So when we look at the fibroids type 0 to completely intracavitary pedunculated fibroids, then type 1, 2 up to 3 and 4. Now again, after when we look at what can cause infertility and subfertility as far as these fibroids are concerned, type 0, type 1, type 2, type 3. These are the major types of fibroids which we should be looking to when we are classifying fibroids, especially as a sole and standalone cause for infertility. We always know that they are associated with infertility. The proportion is quite less, 5 to 10%. And the only cause of infertility which can be attributed to fibroids is just 2 to 3%. So we really have to rule out other causes of infertility, subfertility, including male factor, when we are giving this fibroid a villainous shape while we're discussing our treatment options with our patients. So let us explore whether is any effect of fibroid on fertilization, because that's primary event. It does interfere with sperm or ovum transport, especially if there is enlargement and deformity of uterine cavity. It can impair uterine contractility. We have enough of data. Although recently it has been challenged, but majority of the papers are saying that uterine contractility, which we also believe is impaired, especially if the intramural fibroids are placed and that too larger ones. It can distort the position of cervix, and it can distort or obstruct the tubal osteo also. The effect of implantation failure or gestational discontinuation in presence of fibroid. There is alteration of endometrial contour. There is persistence of intrauterine blood or clots. There is focal endometrial vascular disturbance, endometrial inflammation, secretion of vasoactive substances, and enhanced endometrial androgen environment. But none of these putative mechanisms has been confirmed to be etiologic factor, but yes, they are contributory factor. So when we look at the mediators, when we're talking about the effect of fibroids on fertility. So tubal obstruction, it is due to mechanical or space occupying fibroid, compression endometrium and distortion of cellular morphology, dysfunctional functional uterine contractility and peristalsis, disturbance of junctional myometrial zone, disruption of angiogenesis, inflammation, fibrosis, and impaired endometrial receptivity. Now, more than infertility, it may be associated with implantation failure, because this angiogenesis, there are so many mediators which are disrupted, and we all know that we require vascular remodeling when the placenta is being invaded, and especially fibroid, if it is placed at the site of implantation, the patient may land into implantation failure and may abort earlier. When we talk of fibroids and IVF, we can get so many answers. IVF, because it is providing a good model to assess the effect of fibroid on implantation rates by excluding other factors such as tubal or male factor. But on the other side, IVF cannot assess the effect of fibroid on the sperm migration and ovum transport. But it all depends on the type, size, and number of fibroids. Intramural fibroids halves the chances of ongoing pregnancy following IVF. This was data given around 24 years back. Now, this one large study by Mitwalli et al. Is worth quoting. They said that there is no evidence of a significant effect for intramural fibroids on pregnancy rate or miscarriage rate. And these are probably the pregnancies that we were discussing just before this particular talk. And there is no evidence for a significant effect for myomectomy on pregnancy rate or the miscarriage rate, because we all have been practicing for at least this much long time that we have seen our own patients in whom myomectomy was done or not done, and we have seen pregnancies in these girls. So the type of fibroid is basically where it is located is the most important one. Submucous fibroid will have most detrimental effect cumulatively. Intramural fibroid may have a modest impact, but subserous fibroids, they're least impacting the rates of pregnancy in the patients having fibroids. So size of fibroid, basically intramural ones. So there is no statistically significant difference in implantation rate or pregnancy outcome. And let us see the size which has been studied in relation to the size of fibroids since the years. So in 80s, it was believed that if fibroids are less than 3 centimeter, they will not disturb the pregnancy. And coming subsequently, we believe that fibroids as large as 7 centimeters will not disturb the pregnancy rate. Small intramural fibroids, they significantly reduce the cumulative pregnancy, ongoing pregnancy after 3 IVF ICSI cycles. That's the data from 2006. And fibroids, if they're having size more than 4 centimeter, required an increased number of cycles to obtain an ongoing pregnancy. The number of fibroids, again, when we talk of 3 to 5 centimeters and their relation with pregnancy rate. Less than 3 centimeter to more than 3 centimeter, obviously the number of pregnancies were reduced as compared to the controls where there were no fibroids. Distance from endometrium is also an important factor. If the fibroid is placed for more than 5 millimeter from the endometrium and especially from the junction, there seems to be no effect on ongoing pregnancy rates or infertility rates. So how do we evaluate our patients for fibroid? Because again, patient, if having fibroid, will be asking whether, however great counseling we must do, she will ask us whether she'll be pregnant or not. So we will give her a good answer after giving one ultrasound, because it is the first line imaging examination in suspected fibroids and shows high sensitivity and specificity in diagnosing this condition. We can see characteristics of fibroid on this ultrasound: uterine enlargement in toto, distortion of uterine contour. There may be varying echogenicity depending on the amount of smooth muscle tissue, hypoechoic or hyperechoic. And along with this, we can see calcification and cystic areas of necrosis or degeneration, which can be identified earlier. If we let the color flow while we are doing ultrasound, it allows us a differential diagnosis between intraligamentary located fibroids and solid ethnic cell tumors, because blood flow on the periphery is of clearly uterine origin, and uterine arteries present lower impedance to blood flow in this area. Then fibroids grow centripetally, creating a pseudocapsule of compressed muscle fibers, and color Doppler demonstrates the vascularization of the periphery of the fibroid and allows a better delineation of the tumor. So it is always advisable to add color Doppler while we are evaluating ultrasounds. Transabdominal ultrasound is done when the size of uterus is more than 12 weeks, and TVS is good if we have to assess other pelvic pathologies also. It is more accurate, more sensitive, especially for smaller fibroids. It is good in obese patients and can exclude endometrial hyperplasia. But yes, it is warranting more investigation if we have to differentiate between submucosal fibroids and polyps. So submucosal fibroids are typically seen as broad-based, hypoechoic, well-defined solid masses with shadow. Submucosal fibroids have an overlying layer of the echogenic endometrium, which helps confirm their subendometrial location and distinguish them from endometrial polyps. Also, as opposed to polyps, submucosal fibroids often distort the interface between endometrium and myometrium and show acoustic attenuation. When internal vessels are evaluated, a submucosal fibroid will typically have multiple feeding vessels as opposed to the single vascular pedicle for an endometrial polyp. Now, this I call as a very, very important sign to differentiate between a submucosal fibroid and a polyp. The most important signs, those are two, like we tell our postgraduates also, that a submucosal fibroid will be having a broad base, polyp will be having a small base, and submucosal fibroid will be having a good feeding vasculature and pattern, And this polyp will be having almost majority of the times a single vascular pattern. So these are the features and color Doppler peculiarities, and these are helping us to differentiate between a polyp and submucous fibroid, and this I have already discussed. Intramural fibroid is the most common type of uterine leiomyoma in terms of location. They are centered primarily within the myometrium. A large intramural uterine leiomyoma can, however, have a submucosal or a subserosal component, and that becomes a hybrid variety. Intramural fibroids are well-defined, hypoechoic, homogeneous, rounded lesion with peripheral hypoechoic rim. And this causes enlargement of the uterus, distortion of the contour. Sometimes heterogeneity due to degeneration or calcification can also be seen. On a Doppler, there is evidence of enough peripheral vascularity, which is diminishing as we go towards the center. Adenomyosis is a different like entity which has to be differentiated, and especially we heard the great discussion going on between Ranjana ma'am and Shobha ma'am. They were discussing that maybe it was an adenomyoma. So if we are evaluating such a patient and we have to differentiate between adenomyoma and a fibroid, we can do so quite well during this ultrasonographic evaluation. It shows altered hyper and hypoechoic image and zones of Swiss cheese pattern that was termed earlier. Now we have so many markers and ultrasound predictors to differentiate between adenomyosis and leiomyoma. There may be multiple small cysts entering into the myometrium, and if we do sonohistography, contrast penetration of the myometrium can be visualized. They generally involve the whole uterus or are localized into one portion, that is adenomyoma. And if we add again Doppler, the penetrating vascularity can be very nicely demonstrated. Sonohistographic image of submucosal fibroid, if we see a 2D ultrasound shows a uterus with a small submucosal fibroid emanating from the anterior wall, this one, and two fibroids emerging from posterior and anterior wall of the uterus in this particular area. Now, how saline infusion sonography becomes a good friend? Because whenever the relationship between the myoma and uterine cavity is unclear, this becomes an easier, less uncomfortable, and less expensive investigation tool. It is usually scheduled between day 5 to 10 of the menstrual cycle. There is no need of anesthesia or analgesia. Just do a bimanual examination, place a speculum, taking all aseptic preparation precautions, and prepare the cervix with betadine. Pediatric Foley's is used and we insert it with the help of long artery. And then after we insert the catheter, around 1.5 to 2 milliliter of water is normal saline is infused, and we just check it after taking it out whether it is placed nicely and occluding the cervical opening. After this, you remove the speculum and attach 10 ml syringe or a sterile saline, insert TVS probe, and we can see that it distends the uterine cavity. And earlier, if we presume that this was a case of endometrial hyperplasia or a thickened endometrium, not hyperplasia, but a thickened ET, then we can see after saline infusion sonography or after the saline was infused, there is clear demonstration that a submucous fibroid sitting silently inside the uterine cavity. So with this, we have increased the sensitivity and specificity with a major gain by saline infusion sonography. With TVS, it is 75 and 76%. With saline infusion sonography, it becomes 93 to 94%. Now, role of endometrial biopsy. If there are fibroids and there is irregular or intermenstrual bleeding, and if we demonstrate abnormal endometrial thickening or TVS, the patient may be subjected to endometrial aspiration, either cytology or directly a biopsy. MRI can be done in uncommon presentations where uncertain location after TVS and saline infusion sonography. When the number of lesions are more than 5, MRI exceeds ultrasound's technical limitation in precise fibroid mapping and characterization. Now, a word about management. We can go for expectant management provided the infertility patients are having no other identifiable etiology except uterine myomas and the fibroids are asymptomatic. Medical treatment is not very effective in improving infertility. Progestin therapy, including OCPs, androgens, mifepristone, GnRH analogs, decrease the size of uterus, fibroid, the volume of uterus in total. But for fertility outcome, directly, the result is questionable. Myomectomy, because many times we encounter patients who are coming with 2 centimeter, 3 centimeter fibroids, and periphery doctors have recommended them myomectomy. So they do come to us for second opinion. So how do we approach them? So if the fibroid is distorting the uterine cavity, especially submucous, regardless of the size or the presence of symptoms, then they can be offered a myomectomy. Intramural fibroids, if they are distorting the cavity, they reduce the chance of conception. Not distorting the cavity, there are controversial results. So all the intramural fibroids more than or equal to 5 centimeters have some submucous component, and they may warrant a surgical consideration. For that, MRI can be done to map these uteri and their myoma and their location. Subserosal, there is absolutely no indication to do myomectomy for improving fertility outcome. And myomectomy of submucous fibroids, there is significant increase in pregnancy rates and a decrease in miscarriage rate after that. But there is insufficient evidence from any RCT to evaluate the role of myomectomy to improve fertility. The data does not support pre-IVF myomectomy in routine in women with the small to moderate uterine fibroids, regardless of their location. So when we talk of a GnRH analog pre-treatment, before we attempt myomectomy, it reduces uterine volume and fibroid size, correct preoperative iron deficiency anemia by reducing blood loss, reduces blood transfusion rates and complication rates, but there are not statistically significant, and there is no significant impact on operative time, difficulty, or complications. Route for submucous myomectomy, the choice is hysteroscopic. And for intramural and subserosal, it is laparotomy or by laparoscopy. The counseling has to be done for multiple large broad ligaments, especially for the injuries associated, for cornual placed fibroids, for cervical fibroids, and they should always be explained about the risk of conversion to hysterectomy. Determine small and buried fibroids within the myometrium and ensure their complete excision, and giving oxytocin, as I was just hearing, and misoprostol also can delineate them very nicely while we are doing myomectomy. Open myomectomy, it is the route of choice for large subserosal or intramural fibroids. Multiple fibroids when entry into the uterine cavity is to be expected. Hysteroscopic myomectomy for submucous fibroid as compared to laparotomy is associated with lower risk of scar rupture and no pelvic adhesions. In large varieties of type 2 submucosal fibroids may be unsuitable for hysteroscopic surgery, and a significant benefit of removing submucous fibroid more than 2 centimeters has been demonstrated. So how do we decide and choose? So this is the scoring of myoma using a newer classification. For we take into account the degree of penetration of myoma into the myometrium, the extension of the base of nodule with respect to the wall of uterus, the size of nodule, specifically whether it is less than 2 centimeter, 2 to 5 centimeter, or more than 5 centimeter, and their topographic location in relation to the lateral or anterior wall. We add an extra point. So if the score is 0 to 4, they are placed in group 1. This is low complexity submucous fibroid, and hysteroscopic myomectomy is done. For group 2, the score is 5 to 6, and complex hysteroscopic myomectomy is expected. Consider giving either a pre-operative GnRH analog and perform a 2-stage procedure, or maybe both. And for a score of 7 to 9, they're placed in group 3, they are unsuitable for hysteroscopic myomectomy. So lap myomectomy, pedunculated or subserosal, these are not actually our candidates, especially in relation to fertility or infertility. Intramural, depending on the size, position, and fibroid, and especially the skill of the surgeon, suturing skills, and the instruments available. How much time we take for endosuturing. So there is no significant difference between the laparoscopic and open approach regarding fertility performance, and the results of hysteroscopic and laparoscopic myomectomy are similar to those following abdominal myomectomy. there is one important issue when we are doing abdominal myomectomy, especially, that is formation of adhesion. So a good surgical technique and having anterior incision, the approaching them from anterior side and surface, can reduce formation of adhesions. And adhesion barriers, especially interseed, if you're using, they're very effective. And GnRH analogs prior to surgery will not reduce post-operative adhesions. And we just heard in the previous talks that in fact it will land the surgeon in dilemma, because the planes are lost and seedling myomas are also lost while we have given that. So pregnancy outcome after myomectomy, miscarriage rates are definitely reduced, but there may be uterine scar complications later on, like adherent placenta previa and uterine rupture also in some of the cases. Uterine artery embolization should be avoided in these patients who desire pregnancy. And until more information is available, these approaches should not be considered standard treatment for women who wish to maintain their fertility. So a focused ultrasound, again, this treatment involves application of MRI directed beams, and they heat the area of fibroid tissue up to 70 degrees centigrade and cause destruction through coagulative necrosis. But indicated for premenopausal women only with symptomatic fibroids and who have the desire to retain their uterus. It is not recommended in fibroids which are resectable with hysteroscope, heavily calcified fibroids because the treatment will fail, fibroids more than 10 centimeters, but people are trying that. And when intervening bowel or bladder could be damaged by treatment. So conclusion to give today for myoma and infertility. They are the causes of infertility in a relatively small percentage of patients. Medical therapy of myomas is not effective for improving infertility. Surgical therapy should be recommended after complete evaluation of other potential causes of infertility. Patients with recurrent miscarriages or pregnancy complications due to myomas should be treated after thorough evaluation. All other potential factors have been completed. Because current medical therapy for fibroids is associated with suppression of ovulation, reduction of estrogen production, or disruption of the target action of estrogen or progesterone at the receptor level. And it has the potential to interfere in endometrial development and implantation. And there is no role of medical therapy as a stand-alone treatment for fibroids in infertile population. Pre-op assessment of submucosal fibroid is essential to the decision on the best approach of treatment. And in infertile patients, cumulative pregnancy rates by lab and mini laparotomy approaches are similar, but the lab approach is associated with a quicker recovery, less post-operative pain, and less febrile morbidity. There are lower pregnancy rates, higher miscarriages rate, and more adverse pregnancy outcomes following uterine artery embolization than after myomectomy. And studies also suggest that uterine artery embolization is associated with loss of ovarian reserve, especially in older patients. In women with infertility, an effort should be made to adequately evaluate and classify fibroids, particularly those impinging on the endometrial cavity. So before disposing of our patient for a 2 centimeter, 3 centimeter fibroid, kisse kuch nahi hoga, let us be very, very sure that we are not placing onto a submucous fibroid. And if it is there, we should treat it appropriately, for which pre-op assessment of submucosal fibroid should include assessment of fibroid size and location, that is a step W or Lastmar classification, evaluation of the degree of invasion of the cavity and thickness of residual myometrium to the serosa. A combination of hysto and transvaginal ultrasound or histosonography are the modalities of choice for these patients. SM fibroids are managed hysteroscopically. Size should be less than 5 centimeter, although larger fibroids have been managed hysteroscopically, but repeat procedures are often necessary and cumbersome also. And in women with otherwise unexplained infertility, SM fibroids should be removed in order to improve conception and ongoing pregnancy rates. And removal of subfibroids, subserosal fibroids is absolutely not recommended. And there is fair evidence to recommend against myomectomy in women with intramural fibroids and otherwise unexplained infertility, regardless of their size. Thank you.
I would now invite our chairperson for the session, Dr. Seema Pandey, ma'am. Ma'am is Director, Seema Hospital and Eva Fertility Clinic and IVF Center, Azamgarh, UP. She is ICOG Governing Council member, President of Azamgarh Obs Gyn Society, National Executive Committee member ISAR 2018 to 2021,
Sheela, you have covered vastly everything about fibroid and infertility. That was an excellent talk. And thank you, Ranjana ma'am, for making me part of it. And talking about Sheela's talk was ice on the cake. So, friends, yes, infertility with fibroid is a kind of enigma nowadays. Everyone, and I think whomsoever we are putting our knife on the uterus, we are finding small fibroids, myomas, adenomyomas, anything. So the need of the hour is to change our lifestyle, because the kind of rage we are seeing, it can't be, because everybody is becoming hyper estrogenic. That is due to the lifestyle choices we have, the kind of food, preservative and everything we are having. So these are environmental disruptors definitely playing a role. Regarding removal of myoma, as Ranjana ma'am was talking in earlier talk, that after cesarean it has disappeared. So even I am of opinion, I'm very conservative when I do cesarean. I say it is a new life for the woman, and I don't disrupt anything, I don't remove anything at that time. That is my dictum too. I was taught by my teachers that way, and I still follow that. Regarding infertility and myoma, anything which is distorting the cavity, you have to remove. That Sheela is covered very well. As per latest guidelines and recommendation, a lady with unexplained infertility where you are not finding any other cause, and there is a myoma which is not submucosal, intramural, you can remove it, and it has been shown that sometimes it improves the result. That is the only indication where your asymptomatic intramural myoma you have to remove. Lesser ma'am, pranam. Manju ma'am. Lovely seeing you. Yeah. And whenever you are going to treat, surgery is the only option. Nothing else works when it comes to infertility. Otherwise, you will decrease the chances of conception. You will delay the time to conceive. So either surgical management or no management is the only way with myomas. Choose your battle wisely. What are you going to do with your patient?
But
Thank you.
Sheila, as you were saying, I was also reading that in the West, nowadays in US, they are hooked on to uterine artery embolization. And they have found sometimes that while the patient has undergone treatment, so the patient conceives also spontaneously. So they are taking it quite often, but it has got its drawbacks, like sometimes pelvic infection is there, sepsis because leukocytosis occurs, and C-reactive protein goes up, and the pain continues for some time. So this is the drawback, but they are preferring it because it is a minimally invasive technique.
Ma'am, one thing I would like to add regarding it is with pinch of salt, that American surgical technique and time it takes to undergo surgery. I will not comment on that. But uterine artery embolization is just like uterine artery ligation we do in our complicated
Yeah.
cases, and from all the other places parallel, and all those circulation they develop and they take over. So in ideal situation, it shouldn't be done, but given a chance where you don't have any other option, if we are doing uterine artery embolization, that is not going to make you sterile, definitely.
No,
Yes, but
here to afford, definitely we go in for myomectomy
Yeah,
only.
it shouldn't be the first choice, but given in certain circumstances,
Yeah.
if somebody is choosing.
ma'am,
If she's
if you are
unfit for surgery, if, I mean, due to some other, diseases she has. But then why would she
Correct.
want to become pregnant with that?
Ranjana ma'am, I just remember one case when I went for
Hi, Dr.
laparoscopy
Shobha.
training. Hi, Seema. Hi. Very nice to see you,
Lovely
Seema.
talk. I
Thank you
kept
so much.
listening
Thank
to.
you so much. So I just wanted to share with today that when I went for my laparoscopic surgery training with Dr. Kurian Joseph, Chennai. Okay. Now, what happened in the training session is one patient with a well-identified myoma of considerable size, symptomatic, was taken for myomectomy. It was a kind of, we were all the trainees, and the theater was full of trainees, and he has put in the scope, and for the love of God, the myoma could not be seen on the uterus. He couldn't make out where the myoma was. Anterior, he would look posterior. It was a diffusely enlarged uterus, and it was not defined anywhere. But the woman had symptoms, and the imaging did show. He got the images also and saw there was some myoma there in the anterior wall. So then what he said that, there is some doubt whether the myoma or adenomyoma or whatever it is, since it is not well defined, we will not disturb the uterus. And he went ahead and did bilateral hypogastric artery ligation. And then after a few months, we actually gave feedback to trainees that the patient is symptomatically better. Now, regarding this discussion about uterine artery occlusion methods, I think not suitable for women who are trying for fertility, definitely. Yes. That is not the patient choice here. But in case it is required, then I think we must go ahead and master the laparoscopic
unilateral.
And we should master, because I think Seema is very correct in saying that, as I started the conversation also by saying that we have very few cases to operate as gynecologists. We have very limited options. Why give away our cases to parallel disciplines? Exactly. And also, and really, I also feel that. And radiological embolization is invasive in two ways. Once it exposes to the X-rays and also to the aftermath of that, the kind of necrosis which happens is different from what vascular occlusion will produce. It is different. So the myoma really disintegrates and comes out, which does not happen when you do a bilateral uterine artery surgical occlusion. It doesn't happen. It only decreases the vascularity. So therefore, I think that ligation of the uterine vessels, we should also become adept in addition to myomectomy. I think the generation next should look towards becoming more proficient laparoscopically rather than referring to radiology.
That is,
ma'am, I have a question.
Start, ma'am.
Ma'am,
all the complicated surgeries are younger generation, and even ourselves, we are forgetting doing all those complex surgeries.
Ma'am, I have a question.
Parul.
Ma'am, as you must be doing a lot of laparoscopic myomectomies, so sometimes, like for patient for infertility, when they come and we do, or they have undergone lap myomectomy sometimes, and then they come to us, so there is a lot of fluid in the endometrial cavity, that is isthmocele formation, and that is very common in patients who have undergone surgery. So how can that be avoided? Like how to suture the bed or some way wherein this isthmocele formation can be prevented? Because patient underwent myomectomy for infertility, and post-surgery, they have significant fluid in the endometrial cavity wherein the embryo will not implant. So the infertility stays.
So Parul, according to me, the first dictum of surgery is not to open the endometrial cavity. And if we are opening it, we should be suturing it properly, just like in cesarean. Everybody doesn't get these isthmocele. Earlier, never used to recognize this entity, since single layer closure, no non-peritonization, and all those things have become very rampant. These things we are getting. So that crux is in suturing it properly, I think. And I haven't come across a single patient of ours or anyone's post myomectomy with isthmocele. Have you seen it?
I have seen it so commonly, like in a month, I'm dealing with such 5 patients whose embryo transfer is pending, and they come from very senior surgeons wherein the isthmocele is there. So they are
so you have to get an expert laparoscopic surgeon to your unit, and along with him,
ma'am, they come from expert laparoscopic surgeons to us after that myomectomy for the IVF thing.
Nahi beta,
The
you
thing
must
is, we have
find a way
multiple
to repair
fibroids.
it again. You must find a way, because anyway you have put in the scope, that's why you know the story, right? So
Yeah.
at that time you must nicely repair. You should be prepared to do that.
Yeah.
You must repair it well, because the success of
I feel,
long-term success of
I
myomectomy depends on that only, on adequate repair of the
You know,
myoma.
I feel if the myoma is big and it is intramural, it's better to do it, with the open technique, and we
Yeah.
can, shape up the uterus again properly. There must not be any distortion of the uterine cavity. And don't try to tamper with the endometrium. Just try to leave it alone as far as possible. But then she's saying expert people have been doing that. So
Because
she
there are
is
patients with multiple fibroids. Like if a patient has 20 fibroids, not all 20 fibroids need to be removed. So only the ones which are indenting the endometrium are removed. And sometimes when they're indenting the endometrium, the cavity might get open. Surgery and then suturing. Importance of suturing comes
Importance
into
of being a surgeon and not being a very fast surgeon, right? The meticulous repairing and seeing and ensuring that we are not leaving any area unsutured in the myometrium is the key.
You know, in cesarean section, we don't stitch the endometrium. So is it possible that in myomectomy also we should not suture the endometrium? Is it necessary to stitch the endometrium?
During cesarean, it is more of a decidua and with the embedded vessels lying in between. So, in order that no further proliferation occurs inside, we leave the decidua apart from that. But in general surgeries, why to touch an intact tissue? Like when it is not required, why we
No,
should
I'm
be
saying if the endometrial cavity is incised, when you are removing an.
It's important to suture it, Manju ma'am. It's important
You
to
should.
suture.
You should. Okay.
Yes. It's important to suture. Otherwise, the scar formed is simply not good enough. It will not stand the test of time and pregnancy. It's important to have a 3-layer suturing if there is endometrium. And anyway, the knots are placed outside. We are using a nice material, delayed absorbable. And I think the scarring is minimal. But if we don't suture, the consequences are not okay, because a defect will remain. And in pregnancy, the pressure exerted will not stand the test of.
Can intramural fibroid, a small one, with everything normal, and then she comes with infertility? What should be done? As Seema said, that once the fibroid was removed, she conceived. So why?
That could be coincidental, because normally a small intramural fibroid is not going to cause infertility.
It can cause Ranjana infertility, because that's what I wanted to say, that when we were students, we were told that it is not only the endometrial cavity which is being distorted, which is the result. It is a hyperestrogenic condition, and hyperestrogenemia can also lead to an ovulation.
But nowadays they say it's progesterone dependent also.
It is dependent also. That's different. But it is an hyperestrogenic condition.
Yeah.
And hyperestrogenemia will lead on to
anovulation.
So whenever we are planning the treatment, I think we should always looking for the other investigation, so that we can find out that small fibromyoma, and we leave it and say the God will take care of it. But we should see the ovulation follicular monitoring and try to find out that the patient.
But we could be leaving, even if we remove that one fibroid, it is possible that we could be leaving some seedling fibroids as well.
I think there are very clear-cut guidelines which Sheela has already shared. But there are very, very few indications of operating for reasons of infertility as far as fibroid is concerned. I think today we have all agreed that fibroids are then more often in fertile women than in infertile. So it doesn't really cause infertility unless there is a significant distortion, and unless the size is quite large, which again will cause significant distortion of the cavity. Yeah.
Exactly
So
same thing. Yes, doctor, let Dr. Shobha complete.
Yeah, many surgeons, there is always this kind of sparring between ART specialists and laparoscopic surgeons, or even general gynecologists and laparoscopic surgeons. And laparoscopic surgeons will always feel once you go in any abnormality, you correct it. Otherwise, laparoscopy is not justified. But we must learn also when not to operate. So if we are sure that it is not the cause, then we should not do it. Because I think myomectomy is also not without complications in the long run. It can cause more adhesion, and it can also, take away some of the viable myometrium maybe, but it is important not to create a breach in the myometrium if it is not causing infertility. So now today, actually things are made easy, because I am actually finding it easier to practice today than I used to 20 years earlier, because I feel today the guidelines are very clear. And we can always say, isn't it, Sheela? We can always say, ठीक है, मैंने किया क्योंकि इसमें indicated था, मैंने नहीं किया क्योंकि उसमें indicated नहीं था. So you have a lot of evidence to support your practice. Nobody will question us if we don't do that. And smaller myomas, the direction forward, if no other cause is found in infertility, is like a case of unexplained infertility. The same pathway.
That's what I wanted to say. That all the guidelines in meta-analysis, what do they state? If we read the statement, except for submucosal myoma, myomectomy, none of the myomectomies, they increase the live birth rate and pregnancy rate. That is the statement. So whether it is working as placebo or not, but there is a definite line written there that if patient is not having any other reason, she is an unexplained infertility case, a myoma between 3 to 5 or anything which is lying there, and it is not touching or distorting even, you can remove it. So that is just a part of that. Otherwise, females, they get pregnant with so many big myomas.
Yeah.
To end, I would, which is very important, especially for the young clinicians. Last year, I got one case where a patient was pregnant with 8 weeks, right? And she had 3 to 4 centimeters multiple fibroids. Her size was 14 weeks. So somebody recommended that you abort this pregnancy, get myomectomy done. Otherwise, this will not let the pregnancy grow. She went into the trap. She got it aborted. She got myomectomy done later on. And then she was unable to conceive. She had preterm labor, everything. Then during her 4th pregnancy, she had placenta accreta syndrome. And during cesarean, a peripartum hysterectomy was done. So such radical words should not be professed.
Exactly.
And
it is happening. It is happening. You are absolutely right. HbA1c more than 7, and they are asking the patient to get pregnancy terminated. If there is a myoma, they are asking to get pregnancy
terminated. Yeah. So many people, one female I treated for infertility. She had been infertile for 5 years. And after that, she rings me up and on ultrasound, it was found she had 3 fibroids. So she rings me up. She says, "Ki ma'am, actually my in-laws are saying कि इस वाले बच्चे को abort कर दो. पहले हम लोग इलाज करा ले तुम्हारा अच्छे से, और उसके बाद मैंने कहा उसके बाद बच्चा ही नहीं आएगा, then what are you going to do? You just leave it alone." And सब ठीक ठाक हो गया, and she's got the child.
The treatment has to be individualized. You just cannot have strict guidelines that saying that this is what is to be done in this case, and that you have to see the other parameters, the family history, the other things, so that you can individualize them.
Yeah.
They do over prognosticate, and when you are trying to explain them that since this pregnancy is here, let's check it out and we'll decide what to do.
Let something happen. We will do something.
Nature takes its own course to
of course.
Do NTT.
I think first thing they should realize that it's a miracle that pregnancy has happened.
Exactly.
If we tell them that.
I don't tell them, Baba, मैं तो सिर्फ बच्चा कराने का इलाज करती हूँ, गिराने का तो बात ही नहीं करती हूँ, तो मेरे तो कोई स्कोप ही नहीं है.
Yes.
Yeah. Thank you, Ranjana ma'am. I think I must say.
Thank you, ma'am. It was wonderful meeting you all and lovely.
First of all, I would like to thank our chief guest, Dr. Sunita Tandulwadkar ma'am, and our guest of honor, Dr. Sheela Mane ma'am, for sparing their valuable time and blessing the webinar. My heartfelt thanks to our organizing chairperson and founder president of ISOPARB Prayagraj, Dr. Ranjana Khanna ma'am, for religiously conducting such academic webinars over the past 2.5 years now, since this being our 30th webinar of series Scientific Sangam. My thank you to our scientific expert, Dr. Manju Varma ma'am, who has been our constant guide throughout these webinars. Thank you to our chairpersons, Dr. Preeti Kumar ma'am, Dr. Neeru Sahu ma'am, Dr. Abhilasha Chaturvedi ma'am, and Dr. Seema Pandey ma'am for sparing the valuable time and giving us beautiful insights through their lifetime experiences. My thanks to Allahabad Obs Gyn Society for their association, our constant academic partner, Jagsonpal Pharmaceuticals, and ICOG for granting us 2 ICOG credit points. And my thank you to my co-conveners, Dr. Chitra Pandey ma'am and Dr. Jaiswal ma'am. Thank you to the speakers for the beautiful lectures and for a healthy discussion, Dr. Ranjana Khanna ma'am, Dr. Shobha and Goody ma'am, and Dr. Sheela Jamal ma'am for their beautifully delivered talks.
So bye for all and thanks everyone. And thank you, dear Manjudi, for boosting my morale.
I'll take just 1 minute. Yuliprist
Manju.
solicited 5 mg tablets. Save the uterus. Please prescribe for medical management. Of course, Dr. Ranjana ma'am has clearly told that the liver function tests have to be done prior and during the therapy.
Yeah.
Mifepristone 25 mg is our Fibrostone 25 mg tablets. Then, of course, we have EndoReg, just 2 mg tablets, and a whole range of these progestins that are available. So thank you all very much. And there's a small little video during the time it is playing. You may please leave as we are closing the meeting after the video. Thank you all. See you again.
Thank you.
Good night.
Good night.
Thank you. Thank you. Good night.